Labor is generally divided into 3 sections, and it's not a bad way of looking at it, even though they tend to flow one into the other. And the first one is known as, you can call it early, or sometimes people call it latent, or some people call it prodromal. And occasionally, some people still erroneously will call it false labor, meaning that you're not yet committed for it to keep happening and not stopping today. Okay? But the truth is, there's no such thing as a contraction which is false. Okay? Basically, all of those contractions are doing something to make your cervix work better, to make your uterus work, and to get the baby down and out. Okay? But what a lot of people don't realize is that early, latent, or prodromal labor can take place over days and days, which is another reason why having everybody on high alert by the time you're 39 weeks to go, is it happening, is not in your best interest. Like, it really isn't, because you can start in early, latent, prodromal labor with contractions that might come, 15 minutes apart, 7 minutes apart, 10 minutes apart, 5 minutes apart 3 times, and then 20 minutes. But by the time you had the 5-minute apart ones, you're all excited and you think, oh, this is it. Well, it's almost never in. You know how people are worried about giving birth while they're brushing their teeth? Honestly, that's the one we should all hope for. What really happens is that this is in some ways a harder phase than later labor, even though it doesn't hurt as much for most people, because you don't know how long it's going to go on and off for. This is what I would call the big patience test, okay? And this is where it's very interesting. If you study different cultures around the world, traditionally every single culture has almost the same approach to this, which is you're supposed to ignore it, and it would be shameful to even indicate that you're in labor. Now, we can dump the shame part, okay? The shame part is not so important, but the truth is that if you pay a lot of attention to this, it's a little bit like, watching a kettle boil or something, one of those things. As soon as you start watching it and paying attention to it, it often doesn't really get going too much, all right? So let's just do an overview, and then we'll go through what to do in each of the phases. So this takes us from your cervix being not really dilated, although in some people it might be up to 2 or 3 centimeters, up to about 3-4 centimeters. But there's something really interesting I'll tell you in a few minutes about the new research on this. So let's say that takes us to about 4 centimeters. Then we have the okay, we mean business part, and that's active labor. Okay? Active labor takes you from about 4 centimeters to 10 centimeters. Now, just so you know, it's not like babies have measuring tapes themselves, right? We made it up, the 10 centimeters. Obviously, it just means that the cervix is gone over the head, because if you have a baby that's 5 or 6 pounds and someone else has a baby that's 10 or 11 pounds, obviously the actual centimeters are a little bit different, right? So, which also helps explain, sometimes if you have 2 different people looking after you in labor, you're doing great, you're going along, but someone will say, oh, I think your cervix is 5 to 6, and someone will say, oh, I would have said 6 to 7 or so. Don't ever sweat it. The bottom line is if you're going in the right direction, it's okay. Okay? Don't sweat the numbers too much. So active labor takes you from about 4 to 10 centimeters, and when the cervix is all gone, now the head can start coming down through the pelvis really nicely down towards the outside, okay? And that's your second stage of labor, okay? And for most people having their first baby, any idea how long it takes? Anybody? Whoa, that would be hard. The second stage? Pushing for 12. Yeah, the whole thing, 12 hours is pretty common for lots of people. But second stage, the point at which you're pushing and the baby's head comes down and all of that and out, about 90 minutes. Pretty common for first-time parents, and about 40 minutes for second or third-time mothers. And usually, overall, if you add an epidural, you usually add an hour. Okay? Now, people are different, and second stage can actually be like 3 minutes long. There are some people who go, whoa, whoa, I feel like pushing, and there it is. And you can see them on YouTube. right? Those are always the people who, the people who are standing there going, oh, and they say, do you think it's coming? Yeah, I think it's coming. Whoop, there it is, right? There are those people, right? And then on the other hand, there are people who can need to push for much longer, but it's still normal, okay? It's normal as long as the baby's heart rate is okay, you're healthy, and you're making progress. But we should note that if the mean is 90, what you find is that when you get to 2 hours, for normal healthy labors, only 3%, maybe 4 or 5 at most, about 3 to 5% of women having their first babies are left at 2 hours. Does that mean it's not normal? No, it could still be normal, but it does mean you have to reassess. It does mean you have to go, okay, are we sure you're making good progress? Are we sure everything's normal? We should see something be happening pretty soon, okay? And so that's the range. You can see from 2 minutes to around 2 hours for most people happening in the middle. Yeah.
I'm just wondering, is there a genetic link to this? Like if your mom had a 20-minute baby, as my mom did?
Well, it's such a good question. We can't answer that completely, but what we can do is answer it a little bit. We know that certain pelvic types, for example, are associated with faster births than others. Anthropoid pelvises, for example, are associated with faster births. When you have those running in a family, yes, is the answer. We don't really understand. There's a big mystery about the hormone oxytocin that makes your uterus work. We still don't fully understand it. And here's an example. If you put a group of women laboring in the same room, within 3 hours, they will all speed up and they will start to have contractions sort of at the same time. Ever had that summer camp experiment where you go and within a month and a half, all the girls have their periods at the same time? We don't know how that happens. It's been observed now for a long time, but we don't know why that happens. And that's why when I say things like, turn the lights down, turn your phones off, and be quiet, it's not because I'm trying to tell you what to do or say, this is the way you should have your birth. It's really just biology. It's physiology. There's certain things that are really associated with oxytocin working well, and some things that don't work quite as well. Yeah.
Is that time frame the same for twins too?
Oh, that's a really good question. Twins can be quite different actually, because sometimes one twin can be born and you can safely wait for hours for the other one. Yeah. Sometimes they come right away, and yeah, and there's even famous cases of twins born days apart, but that doesn't happen very often. For example, the only time they would do that now is, let's say you have twins and one baby was born and the baby was really born a bit early, okay? And it looks like everything was stable for the second one. They might keep somebody in hospital and observe them, thinking that it's a better thing for that baby to stay longer in that environment. It's pretty rare, but it happens, right? But it's not uncommon when people are managing twins to say, what's in the best interest of this baby? Is the baby well oxygenated? Is the uterus doing well? They may wait for a little while. They don't just rush necessarily to get the second one out. That's a really great question. So we're starting to get a picture. We've got early labor, we've got active labor, and we've got the second stage, right? Now that still leaves us after second stage with one little last bit, which is the placenta. The third stage for the placenta happens either physiologically, which means we don't do anything about it, it comes out on its own, and most of them come out by 8 minutes. By the second contraction, usually, they're out, usually by about 8 minutes. Otherwise, people will give someone a shot of oxytocin, and within 3 minutes, then they pull it out. Okay? Those are the two ways that happens, and that you talk to your midwife about. Okay? So let's look again at this early latent phase. What's really happening? Here we have the cervix changing to be able to become thinner and more open. The two things happen at the same time, okay? So the thinner part, where it goes from being like a doorknob to a mushroom to a fat pancake to a thin pancake to paper, and then pulling out of the way, really that's called effacement, the thinning, okay? And the thinning part is just as important as the numbers. Don't get hung up on the numbers. Sometimes someone can be making great progress effacing, but seem to be a little bit stuck at 4 or 5 centimeters. And then once the cervix gets really thin and they have really good contractions, bang, they just go 2 centimeters an hour and zoom, 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 they're done. So always remember, there's the effacement and the dilation. Don't worry too much about the numbers as you're going through, okay? So this is the most unknowable, the early latent prodromal, because it can start and stop, because your body knows what it's doing. It basically says, okay, we're going to have a run at this. Okay, now we're going to rest for a day, thanks. We just screw it up because we don't let it rest. What happens is we go, last night, hang on, I got to phone 14 people. People come over to the house. We go, last night I was up 4 hours. I think it might be happening. It could be, this could be it. This could be, so everyone's now like on a special, birth watch. And that's not the best way to deal with this, because you get exhausted. So that by the time you go into active labor in second stage, you've had 3 days of not sleeping at night, right? So, not wanting to be unfriendly about all your friends and relatives, but honestly, birth is not that meant to be that much of a social event. Try to rest, take baths, just eat healthy food, stay around each other, no stress, no arguments, none of that stuff, and then you'll see that it'll just take its own time, okay? Usually a few days. Now, your membranes may rupture, and if your membranes rupture, your waters break, that means now you're committed, okay? 75% or so of people will go into spontaneous labor within 24 hours of their waters breaking, but people are going to want to listen to the fetal heart. They're going to want to make sure that the water's clear, the fluid's clear. There may or may not be some interventions, or there may just be waiting. Okay, that's something you're going to sort out with your midwife, but you do know once your waters break at term that you're going to be having within 48 hours you're going to have your baby for sure. Okay, that much you know. But what about things like your mucus plug? Does that predict much? Not really. All your mucus plug tells you is that you're going to go into labor in the next 2-3 weeks. Really? That's all it's just saying, hey, we're getting ready. Bloody show, when people start to feel a little crampy and they go to wipe themselves when they go to pee and they go, whoa, how come I've got a bit of mucus and I've got some blood on it? Or, it's pinky show and blood. That tends to be a little bit more associated with labor in the next 48 hours. Okay? People are a little different, but generally speaking, that means things are tending to get going. Okay? So here's the really interesting part. The way we decided what was early, what was active, what was second stage, was created by this obstetrician scientist years and years ago called Friedman. And there was a big amount of research that created something called Friedman's curve. And this is something for you to understand. It helps. Friedman's curve basically says people can go for quite a long time to get to about 3 to 4. Then they should progress pretty straightforwardly at close to 1 centimeter an hour. Okay? The evidence-based stuff says as long as you're going 0.5 centimeter an hour, that's the acceptable limit of slowness. But Friedman sort of said most people seem to go about 1 centimeter per hour once they got from here to fully dilated. Okay? Well, there's been a huge body of research done in the last 5 years that has discredited this, okay? And this is good news for people in avoiding unnecessary C-sections, because what happened was a lot of people who tended to get stuck around here, seemingly get stuck for 2-3 hours at 5 or so, were being diagnosed as failure to progress in active labor. But what we now know with really great research is, in fact, active labor for most people doesn't actually start till 5 to 6 centimeters. Okay? So if you look at the curve, this could go on and off for a little, off and on for a day, and then nothing for 2 days, and then on. Sometimes it can go all, you could wait for a few days and come back. And you don't have to worry. As long as the baby's moving, as long as the fetal heart's good, it's all fine. But once you get to around 5 to 6 centimeters, it's true that you will see most people progress at least 1 centimeter an hour. In fact, lots of people will go 2 centimeters or 3 centimeters an hour. People having their second babies tend to go almost about twice as fast as people having their first. But here's where numbers can be useful, because when people say, when will my labor be over? And people say, oh, we really have no idea. That's not really the truth, but there's a good reason why they're saying it, okay? Most of the time you can predict about 85% accuracy when people's labor will happen, like when they're going to be at what point. But 15% of the time you're going to be wrong. And you really don't want to give that wrong information to someone who will then be really upset. But I want to just let you in on some of the numbers, so that if you find yourself at 7 centimeters thinking, I can't go on, I can't do this, I want you to know actually how close you are. All right? So this can take a long, long time. But the good news is for most people, it's not that painful, right? So you're staying at home, you're having baths, you're just, having sex, you're having a great time, you're watching old movies, you're not talking to people, you're not letting anybody bug you, okay? You don't have to have a stopwatch out. When people say time them, you can tell if you've got contractions regularly coming 3 to 5 minutes. I've never met a person who didn't notice without a watch, really. So when, if your midwife says, how often are they? Oh, take a minute then and, time them as you talk to her. But don't be obsessed with the time, with the watches. From about 5 to 6 centimeters, though, you're going to find that most people go at least a centimeter an hour. So that is great news, right? What that means is when you're 7 or 8 and you're weighing up, oh, can I do this? The vast majority of people are going to be at the pushing stage in 2 hours, easily. Okay? And so it's not a complete unknowable, right? So let's go through the coping mechanisms for each stage, what to know, what to do. I think we've got this one, right? Baths, showers, walks, everything except lots of loud, annoying people. Okay? That's your early latent prodromal. Midwives will give you instructions about when they want you to call them. Most people don't need to hear about it till you're in active labor, but if you ever have a worry or a problem, always call your caregiver, okay? It's always better to call than not call if you're upset or worried about anything, all right? A small number of people, very small number of people will have really painful prodromal labors, and for those people, sometimes getting an injection of a narcotic can actually be a fabulous thing. If you're one of the small number of people who experience that, and you have at say 3-4 centimeters an injection of a narcotic, quite often what happens is you go home, you sleep, and you wake up and you're 6-7 centimeters, and it's great, and then you come in. So if you're a person who thinks, oh, I really don't want to have drugs, I don't want to have drugs, it's great. It's a great view. Just understand that sometimes a small intervention for a small number of people carefully placed can avoid bigger ones down the road. So you shouldn't find that this is unbearable. If you do find that this is in any way unbearable, get help. Okay? And most people are not going to find that that's a problem. A couple little practical tips. If your waters have broken, people are going to want to test it and see it. So do something like keep a mason jar on the back of your toilet or a clean yogurt container or something. And when you think to yourself, oh, I think this isn't pee, I think this is something else, just collect it. Because it's much easier. Then they come and they do a nitrazine test and they can tell you what it was. All right? So the other thing is talk to your midwife about what are good ideas for helping you to sleep better. Sometimes people will use some kinds of antihistamines, certain kinds like Benadryl or Gravol or those kinds of things, or sometimes they just have certain kinds of teas and hot baths, but it's pretty easy. This part, our active labor, which we're going to call now more like 5 to 10, this is the part where having the spaghetti nerves versus the fettuccine nerves kind of comes in, and you really don't know ahead of time what you are. You just deserve to have great care, whatever kind of labor you have. The vast majority of people can give birth without drugs and interventions if they want to do that, but nobody should be made to feel that that's not right if that's what they want. You can do these really safely. The key thing is the timing, right? The timing of certain drugs. Let me talk to you for a second about epidurals, though. Epidurals are just an amazing form of anesthesia that have just revolutionized the way you can do surgeries and certain other procedures. And they can be fabulous for some people in births. For example, people who have what you call an occipito-posterior labor, where the head is around sort of looking up backwards, and it's maybe a large baby and maybe not the best fit. Sometimes those people have a really miserable labor. They have double contractions, like ka-chung, ka-chung. They're really nasty. They're throwing up from early on in labor. It's just not a good day for them. It's just really bad. And sometimes you can try a few things, but if they don't work in the tub, in the shower, etc., sometimes epidurals can be great for those people. But I'll tell you where you see a bunch of epidurals where it's not always the best use of them is when people are having a normal labor and they get up to something like 7-8 centimeters. They're doing really well, but it's normal for people as they get towards that transition point between active labor and second stage to feel like they can't do it. It's really normal. I'll have people go, no, I'm not joking. Forget it. I can't do it anymore. I'm not doing this. I can't do this. And of course, if you really want to have some kind of drug, you should have it, but you should make an informed choice about it. And that informed choice can only really be made ahead of time because you are not your best rational self in that moment, right? So the thing to know is that you definitely change a birth to a particular kind of medicalized event which carries its own set of risks. That's what you just need to understand. So for example, most people seem to take quite well to the fact they have to be catheterized, but there are risks with catheterization, issues around the urethra and the bladder. Some people have trouble peeing again afterwards, so they have to be recatheterized. So again, if you really need one, it's a good thing, but you don't want to do it if it was just about if it was about saving you from 2 hours of something that you could get through with really good help. The other thing is, although anesthetists are fabulous and there's very few serious outcomes anymore, it's still not uncommon to get a little bit of leak of spinal fluid, right? And sometimes when that happens, people get very severe headaches. So you can have a perfectly normal birth, but afterwards have a spinal headache, kind of like when people have spinal taps. And so in those situations, they have to lie around for a week afterwards sometimes with really severe headaches. They have to go in for a procedure called a blood patch. All of these things people are going to be okay with. The point is, afterwards people will say, oh, if I'd have known, I was so close to the end, if I'd have known that these kind of things could have been a chance, I wouldn't have done it. So that's why I mention it. I think it's a great thing for people who have really difficult labors, but for everything straightforward, there's probably better options. So let's look at some of the things you can do. First of all, hydrotherapy is enormously helpful for most people. Hydrotherapy is just a fancy way of saying showers and tubs, right? So if you have a shower, putting a shower specifically on your lower back, on your whole back, sometimes draping a wet towel over your whole back and putting pressure on it, keeping people in tubs and in showers works for a lot of people, particularly once they get to this point. Okay? Once they're at 5, 6 and onwards, tubs and showers can just be fabulous and fabulously helpful. The next thing is little things that are around the hospital or at your home, like birth balls. I don't know if you've seen this handout, but this is a good one to look at when you're in clinic. A lot of people find birth balls are a great way to go through labor because it allows them to be supported, leaning on a bed, and be in all different kinds of positions. Their partner can help them from behind. Okay? Some people even end up giving birth on birth balls. They like them so much. But the point is, even if you don't give birth on a birth ball, it's a fabulous tool to help you go through labor and move your positions around. Okay? So the range of positions, you got the old-fashioned thing where people are in hospitals or people are lying down. Usually not the best. Yeah.
Are those just
Yeah.
like the same sort of Swiss balls you have at kind of like a gym?
Totally. You want the bigger ones, usually not the little ones. You want the big enough ones. Yeah, exactly. So lying down, occasionally if people are really, really tired, it's okay to lie down for a while. It's just not the best idea to lie down through most of your labor unless it's already racing. Some people have such efficient uteruses and pelvises that honestly, everything's just going to happen. They could do anything. And if you're one of those people, go whatever brings you the most comfort, you should just do it. Okay? It's a little bit like eating in labor, you know? It's safe to eat in labor. Most people don't feel much like it after that first prodromal phase, but if you feel like it and you want, something from McDonald's, you should have it. You should eat whatever you want, basically, as long as you're not in a high-risk situation, all right? So you've got the tub stuff, you've got the shower stuff, right? You've got the birth ball, and you've got these hands-on positions, right? The hip, put pressure on the hip. You've got moving like this. You've got the penguin walk. You've got all of those things. And what I want to send you home with for homework is thinking about practicing some of those, okay? Look them up, look up different birth support measures and start to just walk through them. Because if you rehearse them a little bit, they will be easier for you when you do them in labor. When you're in labor, everything's new. So if you try something for the first time, sometimes it's a little harder. But if it's a position that you know you like, that's probably gonna work better for you, okay? here's where partners really, really come in, okay? And partners have to think of looking after themselves in active labor as well. Usually people are so devoted and they feel so badly that someone else is in pain that they go, no, I won't eat. No, I won't drink. No, I won't go to the washroom. No, I won't go have a smoke if they're a smoker. And then, you know how you hear people joke about, oh, somebody fainted in second stage? Well, it's a wonder that more people don't faint in second stage, really, given, that people have gone hours and hours and hours without drinking, eating, or anything. So make sure, if you're someone's partner and main support, that you take a little break out every so often and then come back in. Keep your blood sugars up. Okay, drink something, eat something. That's really important. All right? Any questions about the things you can do in active labor? Oh, you look like you're in this. One of the things you'll notice I'm not saying much about is breathing. Breathing's a funny one. For people who really like doing breathing exercises, they find them themselves and they love them. For everybody else, they get nervous that they're not going to do them right. The truth is, your midwife is really great at helping get someone through labor. So she's going to be watching. She's going to be thinking, for this kind of a labor, for this kind of a person, I think this would probably help. And that's one of the reasons that you're with midwives. The other thing they can do is help you with breathing. If you're having trouble and you're kind of panicked, you know what they're going to do? They're going to do something like, okay, I want you to just breathe with me. Just slow down your breathing. This you don't have to practice. Okay? You can just do it with them. If you're a person who already goes to a yoga class and you do breathing, well, you're ahead of everybody, and you'll do it in labor too. But other people feel uncomfortable doing these kind of things, like people are like, oh, this is freaky. I don't want to do that. So I'm not going to ask you to do that. I'm just going to say, if you have problems with breathing, your midwife is going to sort that one out. She's going to help you and just say, okay, I just need you to do this with me, and that will be pretty easy. So then we get to this great period, the second stage of labor. So this is the point at which the cervix is gone, the head has come down, and basically the head really, if it's down nicely, only has about a journey of about 3-4 centimeters really to come on. It's not very far, okay? It's not that far. And the best thing you can do is just let it come down on its own. So when you feel urges to push, and this is the moment at which you feel like you're something out of a horror movie, because have you ever heard this? Have you ever gone on a hospital tour and you hear someone going, "Aah!" and you think, oh my God, that's not going to be me, right? Well, it will be. It might be. And it would be great, because I'll give you this little tip. If you're a caregiver, you love that sound so much because it's so physiological. Right? You just know that means that person's pretty much likely to have everything coming down, smooth and out. Great. So if you feel that, it's usually best not to suddenly go, okay, get your legs up, everybody push, 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 because when heads come down naturally on their own with contractions, they tend to be better oxygenated. The baby tends to be better oxygenated, and so there's really great evidence that unless you have to get a baby down, do that pushing. You don't want to do that kind of purple pushing or Valsalva maneuver if you don't have to. You really don't. And the reason is simple. If you go like this and you hold pressure, basically you don't have oxygen in your body, okay? And you have compression and you have a baby that doesn't get as much oxygen. Once in a while you have to do it to get a baby out, and so everyone's like, okay, we don't have a lot of time, let's do it. And then it's right. But most of the time, the best thing to do when you're in second stage and you feel that is actually just try to breathe through it and let the baby's head come down by itself. Okay? Because the best second stage, smoothest for a baby and for you, is when people don't say, oh, you're fully dilated, you can start pushing. It's when they go, oh, great, we can see the head. All right? And that is just a lot better. All right? So what kind of positions are good for second stage? The truth is all of them. All of them are good. The key thing is usually you want to move between them a little bit. All right? So, and the best positions are the ones that you have the best contractions and the best descent in. And you don't know ahead of time. Depends a little on the shape of your pelvis. Depends a little bit if the fetal head is a little flat or it's in an angle. Depends on a few things. But usually, things like hands and knees, side lying, squatting, those are all good. interestingly enough, there are some people for whom lying with a wedge under their side, close to on their back, actually works really well. You just don't want to have most people in that position most of the time because it can compress the blood vessels and it can mean you don't get as much oxygen. That's why it's best to not, be lying down for any length of time. Okay? So usually about every 20 minutes, half an hour in second stage, you should change positions. The other reason is that if you've still got this amniotic fluid around the baby, when you change position, what you're doing is also shaking that up a little, so the baby's also usually got a little bit more of a buffer zone. Do you know what I mean? Instead of it coming to rest this way. Once in a while, you'll hear people say, oh, that baby's heart seems a little low, and then they'll go, oh, I think it's just lying on the cord. Because if you stay in the same position for a while, they'll like, it's no big deal. Then they'll go, just change a position. All right? So if you think in your head ahead of time, there's no one best position, okay? But you want whatever's giving you the best progress and your contractions are coming nicely. That's the best position for that moment, for that time. So now we have this head coming down, and I want you to understand, people think that a head comes down and it just pops out. Not unless you're the magic toothpaste people, who just like, oh, what happened? It just came out. For everybody else, it's not like that. What happens with a first baby is that you push and see the angle here? See how that angle? Really, it looks almost like you're pushing uphill a little bit, right? Just because of the angle. So what happens is the baby takes a few runs at it. So it's normal that the head comes up, everyone gets all excited, and then the contraction goes away and it goes back. And it does that a number of times. And everyone's like, well, what happened? Well, can't you just grab it or something? What happened? Why can't it just come out? But as long as the baby's heart rate's fine, it's perfectly normal. And in fact, what it's doing is it's just getting these tissues all ready, and it's actually getting its head nicely suited to coming out. All right? Let me tell you about the head. When we come back after the break, we're going to do postpartum, and we'll do everything about babies. But for the birth, you need to know a few important things. This is the part of the head you're going to be seeing first, except it won't be usually quite so neat as this doll, okay? There's a triangle at the back of the head, which is called a fontanelle, little soft spot. And the biggest one is this diamond-shaped one up here, okay? Now, these are amazing things, really, because humans get brains that go really fast, right? They grow fast, they grow big, and so they can't have a head that's just like a little helmet, okay? It has to be able to grow. The other thing is that they're designed to be born through a pelvis, right? So what happens is they have these little frontal bones, they have these bones at the side, parietal bones, and they have a bone at the back. And I'm particularly telling you these details for the partners, okay? Because usually the woman in labor could care less, really. She's like, is it out yet? What's happening? What am I feeling? But the people who are looking are going, what am I seeing? Because what happens with something called molding, right, is that the head gets itself so that it can go through a fairly small space efficiently. And that's, have you seen cone heads on babies when they come out? Well, as they're going through, this bone folds over this bone, and these bones tuck under the other ones a little bit, okay? Now, once in a while, as a baby's first coming out, it can be all white, it can be a little bit bruised looking, it can have some mucus on it, it can have some blood on it. In short, as much as I love babies, I can't say they're all beautiful at that moment, at this moment, okay? So I have over the years seen so many totally stricken and terrified fathers who just want to be supportive, but what they'll say afterwards, and they're like practically crying, they're going like, I thought it was dead. And the reason they think that is very logical. When have you ever seen a head that had jutting bones sticking out of it, right? So it doesn't always happen like that, but it's not uncommon, particularly with first babies. Second babies tend to just kind of rocket through without much because there's been a path open before, right? But with the first ones, what you sometimes see is this one bone over the other one a little. So people are looking, thinking, is that normal? Is that normal? And it is, okay? It's completely normal, all right? The main thing you're listening to at that point is just the baby's heart rate, okay? And as long as the baby's heart rate's okay, no one's going to be in a rush. If the baby's heart rate wasn't okay, they would tell you, and there's a number of things they could do to speed it up. They could do a lift out. They could do an episiotomy. They could get you to push harder, okay? But as long as that's not the case, it's in the baby's best interest to come out smoothly, right? And so don't be freaked out if you see the head looking kind of foldy and strange when it's on the perineum, and it can have, as I said, all the colors of the rainbow and look kind of odd. Some of them have hair, some of them have no hair, right? So what's happening doing now in second stage is, remember I said it's going to go back and then come up and then back and that. And then what it's doing is it's thinning out this area. And so what you want, because everybody wants you to come out without any, we don't want you to need any stitches. Right? That's the idea. And most people shouldn't need them, you know, if everything's nice and smooth. So what happens is, as the head comes up like this, it nicely stretches this area. Sometimes that can burn for people. So if you put something like a warm washcloth on it, or let's just a compress, that, you know, it helps in the way that, have you ever done that thing when you were a kid and you did that mean thing on someone's arm? You know, and then you put, it burns, and so then you put a cloth on it and it feels better. That's what you're doing there. So here's our baby, right? We've gotten over what the baby's head might look like coming out, and it can sit like this for 5 minutes, 10 minutes. That's not uncommon, okay? It can happen, right? It's not going to necessarily all just shoot right out, okay? It just depends. Some of them come out pretty quickly, and some of them will take a little bit of time. All right, that's normal. So then what's going to happen is the midwife's going to ask you usually to just try to breathe with her. Maybe she'll go, just pant like that. Or she might just say, okay, just don't push because the baby's head's coming out nicely on its own. Okay, what you want ideally is that she's going to help glide the baby's head out over the tissue in the front. Okay? Or sometimes people do these things completely hands off, and basically the baby just comes out slowly like that. Okay, so now we have a little head out. All right? So what's going to happen is people might just have a little look. They might wipe the eyes, make sure that, you know, they might wipe some mucus around the mouth. And then everybody worries about the cord around the neck, right? Cords are around the necks of babies a third of the time. It's just normal. It's completely normal. And I think what happens is that people don't want to have to tell people if there was an intervention. They don't want to go into all the details of what caused a fetal heart problem, so they just say the cord was around the neck. But the truth is, cords are around the neck all the time. And here's why you shouldn't be worried about it. Cords are made of this stuff called Wharton's jelly surrounding these blood vessels, okay? And it's incredibly like a buffer zone. All right, it's really pretty. You can, most of the time, you can just pull them over a head, or you can deliver a baby's body through the cord. It's actually pretty rare that you need to clamp and cut a cord. Okay, this is an interesting other area now with new research, which is, it used to be pretty standard medical practice, although never midwifery practice, to routinely clamp and cut just like that. But what happens is a lot of blood for the baby is sitting here in this placenta. Okay? We now know definitively that we should have babies coming out attached to their cord if at all possible. Okay? And we should delay clamping and cutting the cord until it's stopped pulsating. Because when it stopped pulsating is when it stopped giving the blood that the baby needs to the baby. Okay? There's really great evidence now, and now, you know, now you've got neonatologists all going all over the place talking about it, but it's important. Sometimes people want to just quickly clamp and cut the cord, but that isn't what should happen. Okay? Basically, even if babies need resuscitation, increasingly now they say try to have them with the cord intact. And so the reason is because you want to have the blood come through the cord into the baby, and for, you know, a couple of reasons. One is you don't want the baby to be anemic later, but I'll tell you the main reason is that babies haven't been using their lungs hardly at all while they're inside you, right? Because they get everything they need pretty much through the placenta, so their lungs just go like this. They haven't actually gone like that. To do that, they need to have some pressure changes sort of around the chest, and that happens with blood volume. If they're missing a lot of their blood volume, what can happen is you can resuscitate them, they can come around, but 4 or 5 hours later they're going to crash a little and need to go to an NICU or something to be observed for a day or two, because then the fluid from the rest of the body has to go to help support the lungs. Okay? You don't need to know all the details. Just know that you should have delayed cord clamping, and you should never worry if there's a cord around the neck. Okay? If a midwife was actually concerned in any way, she'll just deal with it really quickly. It's one of the easiest things to deal with. Okay? So don't let that worry you. Okay? So I hope we did the freaky head. Say that again? As soon as they're born. Basically, well, when they're still inside you, but the head is out, they can't really expand their chest, right? So it's almost never do you see them breathing on the perineum, right? So what's going to happen now is you're going to wait for a contraction to come, which is going to turn the baby sideways like this, okay? And then what's going to happen is the midwife is going to gently compress the shoulders to minimize any damage to the perineum, and then the baby's going to follow that birth curve and come this way and usually just be there with you. Okay? So at that point, the baby's going to actually go and breathe. Okay? And if they don't do it in an energetic way, people go like this, just to help them, and that's what happens. Okay? Well, the umbilical cord, the thing that people don't quite understand is it's not that the oxygen that they're getting from that is so important, because the reason that we breathe that first breath is because of carbon dioxide buildup. What they need from this is the blood volume to be healthy. It's kind of like if we took a quarter of your blood volume away, you wouldn't feel that good, right? And that's what we're doing when we cut and clamp quickly. We're taking away some of their blood volume, so their lungs and everything don't work quite as efficiently. So I wanted you to have the latest of a couple of areas of big research, and one of them is the stuff about active labor really starting later than people thought, and the other one is that delayed cord clamping is really important, and it should happen really all the time, as much as we possibly can have it happen. Okay? So you were pushing in all different kinds of positions. Okay, remember we said it could be 2 minutes to 2.5 hours or so, but most people, first babies, you're going to look at somewhere between an hour and a half for most people, okay? And you're going to have a head that goes back and forth, and comes out. You're not going to be worried about how it looks, right? Okay, then you're not going to worry that it doesn't all come out at once most of the time, right? Because with the next contraction, which is usually 3 to 4 minutes later, 2, 3, 4 minutes later, you're going to see the baby turn, like hi, and then you're going to see this top shoulder come down, then it comes up and around. We're going to wait for the cord to clamp, and there you go. You've got your baby, okay?